Hi, everyone, and welcome to our webinar today. My name is Jen Elder. I'm the director of the Homeless and Housing Resource Center, and we are excited to have a great panel today to talk with you about identifying and addressing behavioral health needs in encampments. We recognize that this topic is really at the top of a lot of communities' minds right now in how to approach encampments in a trauma-informed way, connect people with services and with housing. So I'm excited. We have a great panel from Circle the City in Arizona and from the USC Street Medicine team in California. But before we get started, I'll start with a quick disclaimer. The Homeless and Housing Resource Center is funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions expressed today don't necessarily reflect those of SAMHSA or HHS. Next slide. A couple of quick housekeeping before we begin. As with all of our events, we are grateful to be joined by American Sign Language interpreters during today's webinar. So we thank Pamela and Dave for their time. We also have live transcription from a human captioner. So we thank Karen for her time today too. If you have any technical difficulties, please reach out to us or drop a question in the Q&A and we will respond to you. Next slide. This is also the very first HHRC webinar where we're offering live Spanish interpretation. We have instructions here on the slide and we will get those to you in the chat in Spanish as well. With that, we do have the slides available today in Spanish, and those are available on our website, and Alicia's put the link in the chat. Next slide. So the final few notes from me. We're joined by a large group today, so all participant lines will be muted and we won't have the chat feature available. But that said, we really want to hear your questions. We know that you have a lot of questions on your mind about this topic, so please drop those to us using the Q&A feature. We'll get to as many as we can during today's session. We received, thousands of questions during registration. We appreciate that. The panel has seen them, reviewed them, and is planning to address those during the panel discussion today. As I mentioned, the slides are available on the HHRC website in English and in Spanish. We'll have the recording available tomorrow. And at the end of the webinar, there'll be a link to a short evaluation. We have that available in English and in Spanish, and you'll be redirected to a certificate of participation. So with that, I think I gave a lot of housekeeping instructions, but if you have any questions, reach out to us during the webinar. But with that, I'm happy to pass it over to Katie League and also express our appreciation to the National Healthcare for the Homeless Council for helping us facilitate and prepare this webinar. Katie.
Thank you so much, Jen. We are delighted to be with you all today and to have a wonderful conversation. But I would like to start with our land and labor acknowledgement. Our conversation today includes all of us who are located across many communities. Most of our communities reside on unceded ancestral lands or acquired by unhonored treaties. We acknowledge the people of these lands, past and present, and honor with gratitude the land itself and its people. We also honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented people whose labor remains hidden in the shadows, but still contributes to the well-being of our collective community. By recognizing the land that was taken from First Americans and the forced labor that was provided by enslaved Africans and Black and Brown people, we strive to take steps towards creating a more equitable and just world for us all. I will drop a link to Native Land, the source of this, where I pulled this from, and then also encourage you to take time to learn about the land where you live, work, spend your lives. As Jen mentioned, we have a really wonderful and filled 90 minutes together. My colleague from the council, Kate Gleason-Bachman, and I are going to start with a little bit of an overview of the behavioral health needs of people living in encampments and cover some principles of engagement and how encampment sweeps affect health. Then you're going to hear from two incredible programs about the work that they are doing within their communities. So Circle the City in Phoenix, Arizona, and the USC Street Medicine team that is in LA and LA County. And then we'll have an opportunity to, after they present on their programs, we're going to have an opportunity to present some of those incredible questions that you all submitted to these panelists to answer from their expertise. And we will do our best to get to as many as possible during our time together. So as I said, we're going to start with a little bit of level setting to talk about the behavioral health needs of people experiencing homelessness. So we know that 21% of people experiencing homelessness have reported having a serious mental illness. And it's really important that we focus on the have reported, because anytime we see these numbers, it should be assumed that they are an undercount. That is both because this is a topic and something that people are not necessarily comfortable and forthright with sharing, but also that we know people experiencing homelessness live in the shadows of communities. And the number of people experiencing homelessness is underreported. And so the conditions and health concerns that they have are also underreported. So 16% of people experiencing homelessness also report having a substance use disorder. We also know that as of last year, 39% of all people experiencing homelessness in the US were unsheltered. So when we think of the categories of homelessness, we know that nearly 40% of all people are living in an unsheltered environment. And then when you look just at individuals, so not taking into consideration families, that percentage jumps to 50%. And a lack of stable housing and challenges meeting the basic needs make addressing behavioral health needs that much more difficult for people experiencing homelessness. The relationship between behavioral health conditions and homelessness is complex. It is also bidirectional. And what I mean by that is behavioral health conditions can contribute to a person becoming homeless. So for example, someone with a behavioral health condition may struggle to work a full-time job due to the symptoms that they're experiencing and may no longer be able to afford rent and be able to live independently and support the financial burden of housing and become homeless. Or a person who it may begin experiencing their behavioral health symptoms as a result of their homelessness. So this could be a new diagnosis of PTSD related to trauma, anxiety, and as a result of being unhoused and being uncertain how they are going to meet their basic needs. And this person may begin using substances to try and cope with some of these stresses. And finally, pre-existing symptoms can become worse as a result of being in a homeless state. And so that bidirectionality means there is no one beginning and end. One is not the cause of the other exclusively. We know for a fact that not all people living with a mental health condition or behavioral health condition are homeless, but that those conditions are often made worse by the instability in the lives of somebody who has to live their private lives in public spaces. What we know for supporting people with behavioral health needs and supporting people experiencing homelessness, there are core factors that are the same, and engagement moves at the speed of trust. So we must start with a non-judgmental engagement approach. And what this can include is consistent access to the supports that they need and to the providers that they want to see. So we must meet them where they are, and that we must be consistent and show up to earn that trust, which will open the doors for opportunities for engagement. We also know that consistent access to medication is far more difficult when somebody is living unsheltered. with that, it is essential that we approach working with somebody experiencing homelessness who has behavioral health needs with a harm reduction approach. And what we mean by that, because it can be very all-encompassing, is that we really do start where they are with what their goals are and what they would like to address. And we start by trying to work on the things that they are finding troublesome in their lives, the things that they are looking to change, that are creating difficulty for them. That is what is harming them. And so that is what we define as the harms, not what we might view as the harms, but rather what they identify as being harmful to their lives and to reaching their goals. And we start in those spaces to be able to really move with them towards achieving those goals, which will help with the trust building. And with this, we must be prepared not just to have a trauma-informed approach, but a healing-centered one. And what I mean by that, it is not just enough to assume that somebody may have experienced trauma, but rather that we want to be instruments of not perpetuating that trauma. And so that must mean that we are dependable, that we under-promise and over-deliver in the care and the expectations that we set for someone, that we recognize that we are not just there to collect information for our own interest or curiosity, but rather it must be centered directly around the individual's goals. I'm going to turn it over to my colleague, Kate, now.
Hi, thanks, Katie. Hi, everyone. Thanks for being here. So I'm going to talk just a little bit more about how encampments and living unsheltered can or may impact behavioral health. And I first just want to start by saying, we know, as Katie just outlined, that the experience of homelessness, regardless of the setting, has an impact on people's behavioral health, both in terms of their symptoms and in terms of their ability to get care. So I just want to first recognize that, and then also recognize that the ideal and that what we really want for people is safe and stable housing. So we're talking here about encampments. I am going to talk about some kind of protective and then harmful factors around living on shelters in encampments, but want to first acknowledge housing is obviously the safest and best place for people to be. So as I mentioned, there can be both positive or protective and negative impacts to living in encampments. So in terms of what can be positive, a lot of times there is a sense of community and belonging. People have peers who they know, who they have relationships with, and who they know they can rely on, and that can have a really positive impact on their behavioral health. People living in encampments also often have access to outreach and support services that are coming into the encampment, who know where they are, that they're there, and that they are needing services. And so that's a way for them to access needed resources. Another positive impact can be that proximity to resources, both in terms of people coming in, but also in terms of where they are staying. And so sometimes people stay in a location where they're close to the physical resources that they need, places where they get food, places where they use the bathroom, places where they get medical care, behavioral health resources. So those are all positives. In terms of a negative, we know people can have a very hard time safeguarding their belongings. That can have a big impact on people's well-being and behavioral health. They can be very high traffic, lots of coming and going, high noise locations, which can really impact people. There can be very limited or no access to water, bathroom facilities, ability to shower, to do personal care. The exposure to the elements is quite a risk for people, both physically and in terms of their mental and behavioral health. And then there's a pressure to meet basic needs because of these elements of being unsheltered. People often have to go to great lengths and can risk their personal safety around trying to get their basic needs met. Next slide, please. So as I had mentioned, we often see this kind of mixed impact on behavioral health and people's well-being. And I also just want to point out, behavioral health is quite linked, as we know, to people's physical health and to their physical circumstances. And so these things all contribute to someone's overall behavioral health picture. So as we said, not all attributes of an encampment necessarily have a clear positive or negative impact. So it's important to explore with each person how they're impacted, as well as how best to keep them safe and to reduce any potential harms for them. So there are two things here that we're going to talk about that have a mixed impact, although it's not exclusive to these things. So some of what is protective about living in an encampment setting are a direct result of the impact and difficulty of accessing high barrier shelter spaces, abstinence only shelter spaces, or places with policies that make it hard for people to enter and stay in shelter. And so sometimes people have sought out an unsheltered situation because they have had great difficulty getting into a sheltered space or staying there. In terms of personal safety, encampments can provide some improved personal safety because of the peer relationships and community that we talked about. So because people are present, someone is there to respond to an overdose, someone may be there to help someone who's in trouble, who's having some type of a mental health crisis or even a physical emergency. But at the same time, we know that being unsheltered also exposes people to the potential for violence, maybe just by the nature of living outdoors, not having a place they can really close a door to and be safe. And so we know that this is a two-sided situation. Similarly, access to substances can be have both a kind of a mixed impact on people. So we know access to substances can sometimes be an issue for folks, especially if they have a fear of withdrawal. And so for people who are wanting to prevent withdrawal, being in an unsheltered space gives them more access to be able to prevent those withdrawal symptoms. It can be very hard for someone who's actively using to stay in a abstinence only or sober shelter, especially if there are not support services for them, as the reaction to withdrawal can be quite physical sometimes. So having that access can be an advantage to people. It's a reason people choose to be unsheltered. However, we also know that having access to substances and using outside can increase someone's risk of overdose. For people who have a goal to decrease or stop their substance use, it can be very challenging when they're in a place where they have a lot of access to substances. And so again, this is something that can be quite mixed. Next slide, please. I want to say a little bit about the recent Supreme Court decision, Grants Pass. So in June 2024, the United States Supreme Court ruled that the practice of fining and ticketing people who sleep in public does not violate the Constitution's ban on cruel and unusual punishment. So while many communities had already been conducting encampment sweeps, a lot of us may be coming from communities where this has been happening, the ruling did provide more backing to the practice of ticketing and arresting people for being unsheltered. And so it is a little different to, move people along, which can be challenging in and of its own right, but to have ticketing or arrests happening at the same time can be even more challenging and have a lot of implications for people moving down the road as they're trying to get into housing. It can have financial implications. Under this ruling, sweeps and arrests can occur without offering any services or making any referrals to shelter or to housing. As we know, in a lot of cases, there is an attempt to provide housing when an encampment sweep is happening or referrals to shelter. This does not have to happen under this ruling. And I do just want to remind folks, this ruling does allow for these practices. It does not mandate them. And so communities can still make their own choices around how they support people who are unsheltered in their community. Next slide, please. I also just want to talk more broadly about the impact of encampment sweeps on health. And this information is based on a statement that came out from the American Public Health Association this past year, about the harm that can happen to people who are experiencing encampment sweeps, who are being displaced from encampments. So there can be impacts to personal safety and trust in the supports that are available to them. So as people are moved along, they do lose their community. They lose folks who were looking out for them. They may be in a place that they're not familiar with. They don't have folks who they can turn to. And so this can really impact safety. People often lose their belongings. Their belongings are frequently thrown away in sweeps. And so this includes medications, including life-saving medications. It may include safer use supplies like syringes or other things that people are using to try to decrease their risk of infectious disease. So it can really be challenging for folks to lose those personal items. People may lose contact and trust with needed medical care and supports. As we said, a lot of times in encampments, there are outreach services that are coming in. When people are being swept and moved constantly, it's very hard for those healthcare providers or outreach workers, community health workers, folks to reach the people they have been interfacing with. They may not know where they went to. And so it's really difficult to have continuity of care. People's ability to continue moving towards permanent housing can be impacted. This may be because of loss of documents. So people often lose their birth certificates, their IDs, any identification is lost when their belongings are thrown away. And so that can really impact someone's ability to get into housing. Similarly, if outreach teams cannot find people, they often then cannot continue a housing process that may be ongoing. I also want to acknowledge that the impact of encampment sweeps and displacements does disproportionately impact folks who have been historically marginalized. And we know this is true for experiences of homelessness in general, and we certainly see this happening in encampment sweeps. So with that, I am going to turn it over to Joseph Becerra from USC Street Medicine to talk a little bit about the work that they're doing.
Hey guys, how's everybody going? Am my camera on? Can you see me?
See you.
You look great.
Okay, I couldn't tell. How you guys doing? My name is Joseph. I'm the supervising community health worker here at USC. Go ahead and go to the next one. So this is just kind of like who I am, what I've done, and kind of like all the boring stuff. Go ahead and go to the next one. Go to the next one. All right, so USC Street Medicine. We bring medical care designed to meet the needs of people experiencing unsheltered homelessness to them in their environment. Of course, we go 100% backpack. We go straight to the patients on the streets, in parks, under bridges, wherever they are, no matter where they're at, we'll go to them. This includes not just outreach to connect patients to brick and mortar clinics, but real medicine right there on the street. So, of course, again, we do 100% backpack medicine. So we go to the patients because we know that a lot of times the patients can't come to us. So the primary care health screen designs to meet the needs of the streets. We see what's going on with them, how long they've been on the streets, what their main needs are, and we do work with acute and chronic diseases, including we do birth control, we do STD treatment and screenings. We do hepatitis C treatment and screenings. So we also give meds for the hep C when needed. We do a lot of substance abuse work on the street, of course, because we know a lot of people are using. It includes long-acting injectables, antipsychotics, the LAIs, and other medications to help patients with bothersome symptoms like hallucinations. We have so many, and like everybody else, there's just so much going on in the streets that have seen that a lot of these long-lasting injectables are amazing, as some of you guys might also be doing it, but it really works and it really helps tremendously. So we do a lot of wound care. That's one of the primary things that we see a lot is a lot of the wounds from either injecting the xylazine or just picking and just living out on the streets, not taking showers, not being able to, self-care. And we do a point of care ultrasound on the street also, which is really amazing because we can let them know if anything's going on directly right then and there. And of course, if not, then as I said earlier, we do try to get them to get x-rays and other types of imaging that they need. So we will direct them either to the hospital or the clinics. We got specialty services like HIV care, behavioral health. We have a street psychiatrist. We have clinical social workers that come down. We do gender affirming care, which is also, we give the hormone injections. We have social works that's with us also. So they do a lot of the case management work with the housing and just getting their IDs and helping them get their Medi-Cal or their benefits. And just a bunch of other stuff that we do right there with them. And enhanced care management. We do a lot of enhanced care management going alongside with them, trying to help them get further and helping get what's needed for them. Go ahead and go to the next one. So who's on the team? All these ugly folks there, except for me right there, of course, but all the other ones. We got providers, which are MDs. We have many PAs that are mostly the providers on there. We have MPs, psychiatrists, and LCSWs. They're also accompanied with RNs. Every team is a CHW, which that's CHW led on the street. So we have all these, but not everybody goes out, right? We have the ECM component. We have caseworkers and admin staff. But with our teams, it's built of the CHWs, a provider, and then an RN. And then we have just different specialties, as you see with the psychiatrists, LCSWs, and the caseworkers. Not all of them are built on a team. We have separate teams for them on separate days. So it's mostly either a CHW, a provider, and an RN, or a CHW, a CHW and RN, or a CHW and a provider. And then so we'll have two areas, and I'll explain the areas that we do, how we do it. And they're led by the CHWs, though. Go ahead and go to the next one. So this is how we decide where we go. Of course, there's a lot of outreach, right? We do a lot of outreach. So these colors that you see are different areas. The green one is the east side. The blue one is our CD1 area. The purple is our Hollywood team. The yellow is our Mid-City. And the one down below, the pinkish kind of one, is our South LA team. So we're geographical. And we're only in the city of Los Angeles. We were in LA County, but LA County is so huge. So as we got our new contracts, we ended up just doing the city of Los Angeles. And because we're geographical, the way we work is we do outreach in these areas that you see, the colored areas, but we do a lot of referrals too. So we got, like, of course, when you see a patient, you think I'm bad, you should see my partner. So we get a lot of referrals through patients. Most of our referrals come through patients. The city, because we work really close with the city, Mayor Bass and her team, we work really close with them. We do a lot of the inside safe sweeps, and we do a lot of sweeps with them. We help get their patients medical care, and when they're going to either shelters, hotels, apartments, wherever they're going, we follow them. We're one of the only teams who continue to follow our patients from the street to no matter where they go. And we'll follow them. We'll keep following them. We've have patients that we've followed for, oh, wow, maybe 6 years, 6 to 5 years, 4 years. We continue to follow them until they don't need us no more, meaning, we've got them situated where they're okay to go to the clinics or hospitals by themselves, or they just say, hey, let me do this on my own. And we're like, great, awesome. We get referrals from, just community partners, from hospitals, the community itself. We'll get phone calls, emails saying, hey, we have this person on this street or that street. And, we'll go check it out and see what's going on there. And external organizations, in-house also. But yeah, this is pretty much how we decide where we're going. So each morning we, gather in a room and we go over just different things of what's going on for the day or the week or the month. And then we break up into our teams. And if anybody has any referrals, we go through the referrals and we try to see them as soon as possible. Go ahead to the next slide, please. Role of the community health worker. So these are the really ugly guys there. So the role of the CHW, community health worker, is we're out there making sure our teams can do their job. So you hear that word a lot, community health worker. In street medicine, a community health worker is so much different than a community health worker in the clinic and the hospital, are just different areas, right? Community health workers and street medicine, what we do is we do a lot of situational awareness, I guess you can call it. So scene safety, we make sure that our providers, our nurses, our psychs, our LCSWs, whoever's on the street, we just make sure they're, I don't want to say safe, but we make sure they can do their jobs without any problems going on. So we're always helping them, and then we're just monitoring the area, making sure people are okay. Usually, as you can see the truck here, what the CHW will do on our team is we're the first person off the vehicle. We go to the encampment itself, the community, and we speak to who we're seeing and make sure everything's okay, that we're needed that day, or nothing's going on that day. But a lot of times if anything is, the community itself will tell us, hey, today's not a good day, or can you come back, or whatever it may be. But so we're the first people that engage with the patients, first people who build the relationships with the patients during the outreach and everything else that we're doing. And then just to make sure again that our teams are just able to be there and do their work safely. So we do a lot of harm reduction. We give out a lot of pipes, we give out a lot of needles and all the essentials that go with both. And not only do we give them out, one thing I'm always telling my team is to always educate the patients. You can hand stuff out, but just because people are doing drugs don't mean that they know how to do drugs properly or safely. So we're just making sure that they're out there not only handing out the harm reduction stuff, but it's a big essential to make sure that people are educated on harm reduction. And that's even people who are using. Of course, the outreach, like we were talking about, outreaching the communities and making sure everybody's okay. We keep engaging either when we come in either with water or some type of, I usually have these bags that a buddy of ours puts together. There is so much in those bags. There's like $40, $50 worth of food in those bags and other stuff. And we approach them, we give those out. So it's been a pretty good engagement wise. It's kind of easy to engage with people on the street. Sometimes people don't think it is, but because our community health workers have a lot of lived experience, that's one thing that we look for, is the lived experience person. Somebody who's, I guess you could say, been there, done that, right? Somebody who's able to outreach and talk to people and let them know that they're okay dealing with us. So we just check truck inventory, making sure everything's on there. And we do a lot of admin duties too with all the charting, because we are in an electronic system that we still have to come back. The community health workers are in charge of scheduling. They're in charge of checking in, checking out, and just making sure everything's, running smoothly on the teams. Go ahead to the next slide, please. Again, role of a CHW is patient engagement. How do you start engagements? Like I was saying, a lot of times to build a patient's trust is letting them know that we know the situation and, how it's going because of the lived experience that most of our community health workers have, if not all. And then sharing stuff like water, sharing stuff just like, even stories, just letting them know that we're there because we care about them and that we are consistent on what we say. So one thing I always tell our team is be consistent. Never make any promises. Never tell them you're going to do something you're not going to do, because they will always remember that. They will always remember when you make a promise and you break it, right? So that's one thing that we do, is always say, never make a promise. Just again, the strategies that we use are really just being genuine, just showing that you really care, just letting them know that you're going to be there when you say you're going to be there, and you're going to continue to just help them. One thing I always say is, I'm never going to promise, but I'm going to promise to help you as much as I can, right? Yeah, just always be engaged and always just be there when you say you're going to be there. Go to the next slide, please. Responding to mental health needs. So behavior health, substance use, utilizing MDT support. So we do have a lot of, our providers do provide MDT, and the harm reduction is a big part of that, with also the substance use. So as you can see, or as you guys know, most of you guys are working in the streets. It's about just giving them the proper and the things that they need to continue to be safe out there, continue just to be okay. you know, do what we can for them to be okay, and just continue to show them that we care, that we always will be there for them. Go to the next slide. Kind of breaks this down more. Oh, that's it. Okay. Sorry. We're gonna go with the next circle of city.
Yes, thank you so much, Joseph. And there's a lot of great questions. Keep them coming in the chat. We will get to many. We're trying to answer some as well in writing, but we will certainly pull some of them into the conversation. And so next I'm going to turn it over to the team at Circle the City. It's located in Phoenix, Arizona. And it is Denise Svensson, Thomas Davis, and Rafael Martinez. Thank you all for being here.
Thanks for having us. Joseph, thank you for getting the ball started. Next slide, please. So I wanted to talk about our connection to care team. Circle the City is set in Phoenix, Arizona, and we have multiple programs. We have brick and mortar programs. We have street medicine, behavioral health, and medical health. We have medical mobile units that can move around. We have respite programs for patients struggling with homelessness and have a medical issue that needs to be taken care of. And so we have all those teams, but we were noticing that there was a lack of a connection, and with the increased sweeps, that our patients were moving around a lot more. So we were noticing a need to get some folks out there and scout out Phoenix metropolitan area to figure out where our patients are. So we tried to do that as a team, the street medicine team, with a medical provider and a behavioral health consultant and a medical assistant and the vehicle, and they were out moving around, maybe with the medical mobile unit as well, but it wasn't a very efficient way of finding folks. And so what we decided to do is it wasn't very effective in identifying the encampments and engaging patients. So we decided to do a connection to care team, where two support staff, patient navigators and a case manager, and we got them a truck, we got them a map, and we put them out there and said, drive around and see where you can locate encampments and make connections with them. And then so now we have this team that's out there once a week, providing real-time information to the mobile street medicine teams by dropping pins to the outreach. So all day long, they're 1 day a week right now. They're looking and finding folks that need support. They're dropping a pin. They're giving us a brief description of what's going on, and they're engaging with that group of what Circle the City has to offer. We're piloting this program with Denise and Thomas, and it was very successful as we're reaching dozens and dozens of folks this way. And I'm happy to report that CTC, Circle the City, has secured funding for 2 full-time staff and a vehicle to take this program full-time. So I'm going to turn this over to Denise and Thomas now, so they can tell you what it's like out there. Next slide, please. Take it away.
For what you can see of the picture is not exactly an encampment. Due to the sweeps, most of our clientele can't stay in one spot. So what you'll see is a lot of makeshift movable like encampments, large umbrellas, shopping carts, blankets, stuff they can pick up and move at a very rapid pace. Next slide, please. Okay. When it comes to prepping, lots of cold water in hot summers, obviously a commodity out here in Arizona. There's a lot of heat strokes with the substance abuse that increases their dehydration. It's a must. We also bring our laptops and phones. That way I can charge and phones to get them connected to any other resource we can find that's available. And of course, the right attitude and mentality when it comes to approaching our clientele. When it comes to mapping out the area, my partner Denise printed out all the heat respites within Arizona, since those used to be large gathering spots for the homeless population. Next slide.
Engagement and building trust when approaching encampments. Compassion and humility is the number one thing. You treat them with respect and they treat you back the same way. Attitude of equal and acceptance. We straight out tell them, we're not the police, you know, hide your felonies, put your stuff away. We're just here to help you. Listening, we respond to their answers. Is there anything we can do to help you? And many are already familiar with the Trust of Circle the City. Next slide.
Now, in regards to safety, one no means no go. Basically, it always comes down to having respect for the patient or the potential patient, should I say, for any individual. The only time I'll ever say maybe to try to convince them otherwise, if they have a wound that needs to be addressed immediately, that they're kind of in denial about, that could either manifest in something worse. But for majority of the time, if they say no, it's best to leave them alone. But also, just tell them that they're here for them, can help out. Be aware of body language. Even though they belong to the homeless population, they're still people. Just like if you're in a grocery store or anywhere else, you're talking to anybody, you can read someone's body language. If they don't want to be talked to, they don't want to be approached, it's okay to walk away for your own safety. There is always a vibe wherever you go. The vibe can range from anything. Now, when it comes to like conversations, it's best to keep it short, but also if the answers are short, like if they go straight to no, yes, I don't know, they may not want to even be addressed and be left alone. I'm sure we all are fully aware of what this population has to endure on a daily basis. So sometimes giving them the space they need is always vital. Oh. And of course, approaching with humility and respect and avoiding causing defensiveness. I'll say from my experience in this entire company's experience, about a good over 90% of them, of our population are very friendly. They're still human and they want to be talked to just like any other person. And approach authenticity and genuineness. What I mean by authenticity is in the sense of you may be in a different position with them and they may be aware of that, but if you approach them like as if you're on the same level as them, majority of the time things will go quite smoothly. And when it comes to the formal assessment, I think anybody can tell when they're being assessed, and it can be highly disrespectful in a sense. A simple good morning or just a talking as a casual conversation can go a long way without trying to assess them like as if they're a product. They're a person, obviously. Next slide.
More dropping a pin for the team. It's more than that. It is important to drop that pin so that teams can follow up on folks. Another thing is it's also important to listen for opportunities to provide support, encouragement, and anything that they need. You can pretty much get out of the story they're telling you. Mental health, substance use, social determinants of health resources, and follow-up visits to encampments. That's something we try and do a lot of is follow-ups to make sure they're still there, they're still in the neighborhood, they're still safe. Next slide.
Thank you.
Thanks, everybody. So I think we're going to move on to our panel, and we're going to hear from the folks who you've heard from with some of your questions. And as Jen said, a lot of questions were sent in when you registered, and we've also seen a bunch in the chat, which has been great. So thank you so much. I know we've been trying to answer some of them, and some of them we'll get to in the panel. I want to start just with addressing a question that I saw in the very beginning, just asking for a definition of what an encampment is. So generally speaking, an encampment is any number of folks, can be very small, 1 to 2 people, but it's people in an unsheltered location who are living somewhere that's not an intended place for people to live, who are staying somewhere. They may have a shelter, like a tent, a tarp. They also may not, they may just be staying in a doorway, but any of those can meet the definition of encampment. And those are all folks who have experienced encampment sweeps or being displaced. So just want to start there. And then I'm going to go into some of the questions that we have gathered from the registration, and then we will answer some of your questions that I've seen in the chat. There's definitely some themes, and I think we'll be capturing a lot of it in the questions that you already sent. So this can be just for anybody on the panel. I'll open it up to everybody. Just to talk specifically about what strategies you suggest or that you are using, and I know you've talked about a few, like Circle the City with dropping the pins to identify where people are so the outreach team can follow up with them. But are there other strategies you're using in terms of sweeps? So for people in cities where sweeps are happening, you know, what do you suggest, or how are you working with people in the face of kind of getting moved on again and again?
Anybody? Or so here in Los Angeles, we are dealing right now with a lot of sweeps. We've always dealt with sweeps, right? Everybody. But right here, right now, and a lot of us do believe it's because the Olympics are around the corner. I mean, it's still years away, but it seems like they're starting to really do a lot of cleaning up here. One thing that we do is we really talk to our patients. We spend a lot of time with our patients, knowing their daily functions and what they do on a daily, where they go to eat, who their friends are, who their family is. We really get to know where they're at daily. So we get phone numbers of family, phone numbers of friends, if they have phones. If you're not here today, where will you be tomorrow? Or if, you know, what does your morning look like? You get up, do you have a routine? Because believe it or not, most people have a routine regardless of where they live. So we figure out what their routines are. And then again, like I said, we figure out who they associate with the most. And we try to just get everybody's info and everybody's locations of where they stay. So believe it or not, in a town like Los Angeles, it's huge. But we tend to find our patients a lot of the times and know where they're at, even when we don't know where they're at. We know we're going to run into them again. And it's been pretty good with that. So we just tend to really find out their daily functions and where they're at all the time. And we tend to find them.
Val, Denise, Thomas, anything you'd like to add to that conversation? I know one of the things that is coming across is people are very excited to hear about your PIN system. So maybe if you could share a little bit about what that actually means in terms of it, if it's a particular program you use and how people have access to it.
The pen, I believe, because well, our company uses iPhones, therefore we can just simply pin it on our phones. So how it works is when we drive around, meet different encampments and different people or large gatherings, we'll pin it, but also talk to the people within that gathering to understand what's going on. Similar to what Joseph said earlier, you try to figure out like what the routines is, because the sweeps been happening. Because one of the things about the sweeps is, we're pretty sure we all can relate to, is the fact that sometimes you can lose track of patients and people. So understanding where they go afterwards is vital. But another thing to add on to that is knowing the resources nearby. Just in case you don't know their routine, you can always see like what shelters are nearby, food banks, even minor respites or heat respite. Because recently they started ticketing homeless out here in Arizona, which makes things a lot worse. So just knowing where they'll go and like helps out a lot.
There's an example, we have an example of just this morning at 8:48 this morning, where Denise and Thomas were out and about before this meeting, and they were at a location in northern Phoenix, and they saw an encampment of 20 people there. And so the pin looks like, let me make sure there's no identifying information, but it looks like that. A map, where they are, and description of the 20 people
And the coordinates, yeah.
and the coordinates. And then when you saw that this morning, what did you guys see when you were out there?
They were cold.
Oh, yeah.
They were
Yeah.
cold. Yeah, it was early, so they were cold. They were just starting to move around, things like that. Like you said, everyone's got a routine they do in the morning. They were just heading off for whether to go eat or find somewhere to shower or whatever.
Mm-hmm. And Phoenix, it's a desert. So in the morning it's cold, really chilly. Today it's going to be up to 80. So in the heat, it's going to be hot. And then the temperature is going to drop drastically again, and it's going to get cold again. And then it's that the extreme heat is pretty much over now. But now this is the newest cycle where you go from hot, cold to hot, and then cold again, and then start. And that's the new routine right now.
So I kind of think we do a little bit something from kind of like the same thing you guys do. We always, every patient we see, we get their coordinates. We say what team seen them, and we put it on our OneDrive. So we keep track of all the coordinates on the OneDrive, which is the same thing as the ping on the map. You just ping it where it's at, and then your coordinates will come up. We copy paste it and put it into our OneDrive, so that way we know exactly where each patient is.
So you guys don't use a national database? Like we have a database here, HMIS, that everyone from every organization puts notes in. And that's where we find a lot of the people.
We
know someone's seen them.
We use that too, but a lot of times you can't rely on people putting stuff in. That's the problem.
Yeah, that's true. That's true.
Yeah.
So, because everybody's part of it. So if you see somebody and don't put it in, it's kind of almost useless, right?
Well, yeah, that's why we try and document. We at least updo their current living situation for their housing benefits, so that they're still homeless and they still need help.
That's really helpful. Thank you for explaining this technology. I think it's really applicable to teams to think about how they can be communicating with other team members on their own team, but also other organizations, which actually brings me to my next question, specifically about encampment sweeps. If sweeps have to happen, which we know in many communities they are happening, we could probably debate if they have to. Would you want services to be coordinated, and specifically including law enforcement? One thing we often hear is that when a sweep happens, the individuals don't distinguish between which organizations are responsible for the sweep and the people who are there trying to help them. So how in your community do you do this? How do you respond to encampment sweeps?
In Phoenix, there was a coordination between law enforcement and between the helping agencies. And we used to have a place called The Zone, where there was hundreds and hundreds of folks that slept around the biggest adult shelter in Phoenix. And that they cleared that huge zone in sections, where they would say, they would put out notices to everybody saying, this section is going to be cleaned out tomorrow, be cleared out. And then so with the local helping agencies, ourselves and the police, people were assisted in leaving that section. They would block it off, saying that anybody stays here, they will be breaking the law. And then so they just kind of kept moving that space wider and wider until it was finally all the way clear. It was clearly marked about no camping anymore, and that the police were closely monitoring that to keep it clear. And there are some folks that we were able to move towards different emergency shelter and housing, but there are some folks that just scattered and ended up in the farther reaches of Phoenix.
And at the time, there was actually places to take them to. There was open shelter beds. There was money given just to open shelters for those people.
Yeah.
There's not those options right now. They have nowhere to take these people when they run them out of the parks.
Now, so those are the larger cleanup efforts. The smaller, more individualized efforts occur at the local police level, where a police officer would ticket folks for trespassing if they're hanging around somewhere too long, and trucks would come by from the police department and load up their stuff
Dumpsters would throw everything away.
and throw everything away. And so those are the smaller individualized, those are coordinated sweeps with agencies. But if that happens around where somebody is, then we're available to help them, but it wasn't organized beforehand the way that the major sweep in Phoenix was.
So here in Los Angeles, there's only really everything, all the sweeps go through the city. So here it's the city, it's an organization called LASA, which is the housing. It's the police and the sanitation. So those four here are all involved together. But one of the good things, so there's two different organizations from the city. One is the Inside Safe, and we are actually developing an Inside Safe team that are just going to go with Inside Safe. So when the Inside Safe right now is happening, they always notify us because we kind of like made it that way now where they really notify us. So the city will notify us and give us a list of who is in the Inside Safe. The thing with the Inside Safe, there's a couple different things. They start the area like a week before. They start telling people, hey, would you like to be housed? They don't tell them they're coming to house them. They just tell them, hey, would you like to be housed? Like, how are you feeling about getting housing? You know, would you like us to help you get housing? They do that for a week. The reason why they don't tell them we're coming today to house people, because then they would invite everybody else and it would be too hectic. So the day of the Inside Safe, they start about 6:30 in the morning. All the entities gather together. They talk about what they're going to do. They start taping off areas and bringing in the sanitation and the police and everybody else. And then they will start targeting everybody that they already have on the list to move. Then they'll bring buses in, and buses will come in and, you know, get the people, the patients, we call them patients, sorry, patients, clients, and they will mobilize them on the bus and then move them to where they're going, hotels, shelters, wherever they're going. So the good thing about it is we do have a lot of contact with the sweeps. We've actually been able to do that recently. It hasn't been all the time, right? And then there's another part of the city, I forget what they call it. It's not Inside Safe. There's one more that basically they don't tell nobody, they just do it. And that one kind of sucks because we don't even know. Nobody knows when they're coming. They post signs. They'll post a sign basically and say, hey, you guys got to be gone by this and this. So we do get a lot of our patients sending us pictures of the signs, or when we go to see them, we see the signs and we're like, hey, did they come in? Well, they said they were, but they didn't. So that's the thing. Sometimes they say they are, and then they won't show up. So everybody gets comfortable, right? They don't start packing up their stuff. And another thing with all these moves, you're only able to take 2 bags. They give you 2 trash bags and say, here, put your stuff in here, and that's all you can take. Or if you have an RV, if you have a tent, you have to give it up. So if you have an RV and they're sending you to a place where you probably can't even go in the first place, a lot of people don't want to give up their RVs, right? They say, okay, we'll give them to somebody, but a lot of times they won't let that happen. It all happens so fast. It's just like so quick. They're not expecting it. They're expected to give up their RVs. I mean, I know I wouldn't give up my RV if I stayed in an RV on the street, because what if I'm put in a place where, maybe I'm not liked. Maybe it's just not a good area. Maybe there's just too much drugs, too much prostitute. Like there's just so much stuff. One thing we've been able to do though is tell them, hey, when you guys do these sweeps, take the whole encampment and put them in one place, because you guys got to understand they've become friends and family with these people, right? And then, one of the problems are, okay, so we put them all in one place, or we don't put them all in one place. They're all over the place. Now they have a curfew. Not only do they have a curfew, they can't have nobody in their rooms. So now their socialization becomes extinct, because you have to be at your room at a certain time, and now you can't bring people in your room. So it's just, it's in circles. But yes, we've been able to at least gather with them. Like I said, we're building something called the Inside Safe team to just be inside with all the patients when it's going on. So we'll know all the time when there's sweeps.
Thank you. I'm going to shift a little bit just to talk about, we've gotten a lot of questions about people who are having a lot of behavioral health symptoms. So whether that's related to substance use, mental health, a combination of both, just a lot of questions about how to kind of approach people and relate to them. So I'm wondering if maybe we can start with just thinking about, like, what are the signs that you look for, or what kind of tells you that someone might be having a challenge, a mental health or a behavioral health challenge of some sort? And then how do you then kind of approach and support that person?
Well, there's two tell signs. Either they're just totally in denial to where they say they don't have any issues at ever, and then I ask them, do you consider being homeless a trauma? Yeah. I said, okay, so there's, some things that go along with that, or you can tell by body language, I mean, there's some people out there that just can't control their body movements at all. And it's just built up anger. It's built up, they've been off their meds, they've been off of things like that. And we pretty much, I go out one day, and then I'll go back out the next day with my mental health provider and my MA. So we'll try and go back to and see the people that we've seen the day before, that I seen the day before.
Yeah, Denise is speaking to our mental health street medicine team, and that's a team of a psych nurse practitioner. Denise is the case manager and a medical coordinator. And then so sometimes she's out there scouting for her own team to be able to follow up on the next day.
I mean, if you know the patient, it's probably a little easier to understand, like the decline or something like is really wrong. I mean, that's pretty kind of obvious sometimes, but if you don't know the patient, I mean, it's basic, behavior,
Yeah.
what they're talking about, if they're seeing or hearing things. I mean, a lot of times you just, have to be patient and talk to them, treat them like humans, right? Just humanize humans, and just, be kind in general to people. And you'll see a lot of the stuff that people are going through at the time, and you'll understand that, hey, this person needs a little bit more than the next. And that's like, they were saying that's when you bring the people who specialize in this field, because it's going to be a lot easier for them than just anyone.
A lot of times we'll go into an encampment, and it's like you said, they're a family, and they'll tell, hey, so-and-so's been not doing so well lately. They're off their meds or this or that. Is there any way you can help them out?
I'll tell you, those long-lasting injectables go a long way.
Oh yeah,
We've seen so much on the street with them, and I mean, they're amazing.
Yeah, because if it's not an injectable, then they're losing their meds every time, somebody's
Exactly.
stealing them, or the cops are throwing them away, or, and they're expensive. They're not, Access is not just going to hand them out, keep handing them out. So I think the injectables are the best way once,
Can you all actually talk a little, there were a lot of questions and interest in the long-acting injectables. So a long-acting injectable for mental health is just a mental health med that, lasts, usually it's for a month. I know there's a few that are a little bit longer, but can you all just talk a little bit about what the process is for that? Like, how do you and actually who administers them, how do you do it, and how do you track, who's gotten their medication and who's due. There were just a lot of questions in the Q&A about an interest in kind of how to do long-acting injectables outside of a clinic setting.
For us, it's just, each patient has certain needs, right? So we're on an electronic tracking system. So that's basically how we keep track. And it's either the provider or the psych doc that would be the ones that are, well, it's our nurses that are usually giving the injectables, but they're saying who needs when they're, talking to them. And the problem a lot of times though with long lastings is a lot of times you have to be on the pill medication for a week or two before you can even go into the long lasting. So that sometimes seems to be the withdrawal, the backfall about it is getting to that part where we can get them on the long lasting. But for us to track it, it's not a big deal because we're on a system that we're able to track it, and whoever's taking charge of that person on the team, it's usually the nurse, she'll I guess put it down on hers of when each person is due for their injectables. So
We use the electronic medical record to keep track of who is receiving the injectable. They have a caseload that they follow, and it's this like nurse practitioner that does the injectables. And it really has been life-changing for some folks that we've seen struggling with chronic homelessness around. And I think one of our patients everybody knew him because he just walked around this area, and once he started the medication, it was day and night. He was able to follow up with his housing manager and ended up housing within 6 months after starting the medication.
Yeah, he's still housed. We still go to his apartment to see him. Yeah. And when somebody gets on the injectables, believe it or not, they come seek you out because they don't ever want to go back to feeling the way they did before.
Mm-hmm.
So they're not going to let you miss the shot. They're going to miss the shot.
Mm-hmm.
Thank you all for that. We've had several questions around safety, certainly for the individuals that you're interacting with, but also for your teams. So when and how do you decide if a situation is safe for you to continue to be in? And how do you leave if you decide that it isn't safe? Like, how do you plan your exit?
Yeah, would you all share the last time you approached something and you're like, whoa, we gotta go?
Oh, we walked into an encampment, and you could tell it was they were coming down. Half of them were still sleeping. It was, and usually we get there in the mornings, they're up and they're moving around. Half of them were sleeping, and the other half were just really agitated. So you could tell it was, Social Security money was gone, or whatever income they had was gone, and now they were all coming down. And I mean, we just don't turn our back, and all right, here's some water, and we just turn around and walk away. You know what I mean? But we don't ever turn our backs on them, and they're not violent toward you. You could just tell it's not the time,
I'm sorry, the question exactly again, just how do you know it's safe to enter an encampment?
Yeah, how do you decide? So what are what's your spidey sense for determining if something is safe? And then how do you decide to leave if you decide it's time to go?
So with us, and I'm sure a lot of people have heard, if they've heard either the Feldmans or myself speak, we use code words. When we see that something's getting a little sketchy, we'll say something like, "Hey, does anybody have a yellow highlighter?" Because we don't carry highlighters. That's a code for the team to know, hey, let's just hurry up, pack it up and, finish what we're doing. That way we can get out of there in a few minutes. Or one of the big words we'll use is, does anybody have a red pin? And when you hear red pin, it's basically drop everything you're doing. If you can grab the bags, grab the bags. If not, leave them. We're getting out of there now. And we've had a lot of those situations, not a whole lot, I'm sorry. We've had situations where we call red pin and everybody gets up and goes. And then what happens is after that, we get back to the office, we debrief. of why and what we could have did different or if we did everything right. But to know if you're going into a encampment and it's safe, a lot of times, so this is just broad, right? Because every encampment is different, and some encampments, most of them, you're only entering because you're already dealing with the people. So you know, a lot of times you're not entering an encampment with a bunch of people. You approach the encampment. That's where the community health workers will go in first and make sure, like, it's a new encampment, who's there, what's going on. But if you're in an encampment where you know everybody, most of the time the encampment itself would tell you when something's not safe. Your patients will tell you, hey, it's not a good time to be here. Or like we had a situation one time where most people probably would have panicked. But the way I know if something's safe, somebody pulls up, one of the parents of a kid that's there, but you know, the kid's older, 30 parents there, they're both homeless. They start the patient that's 30 starts arguing with his mom, and they start like yelling and screaming. Everybody's looking around like, what do we do? A lot of people would have been like, let's get out of here, right? Because it got heavy, and then all these other people were moving around. And the reason why we didn't leave, we stayed. And the reason why we didn't leave, because what you do is have to learn how to understand and read encampments also. Reason why we're okay, we had students with us, and they were like, should we go? Should we go? And I was like, no, hold on, let's wait.
Mhm.
The encampment itself, meaning the people in the encampment, will let you know if they're uncomfortable, then that means something's uncomfortable. But if they're just like, keep on going on with their stuff, that means that's an everyday thing. You know what I mean? That means that it's not nothing to really worry about, that you can go ahead and go like, those guys are always fighting and yelling and screaming at each other. We were doing medical care at the time. You know, my PA looks at me and I'm just like, keep going, just keep going. You know, we'll ease into this and see what we're doing. People were coming, people were showing up. It was okay. Again, some people would have left, some would have stayed, but because we know the area, we know the people, we chose to stay. So, I mean, it's understanding where you're at and understanding where you're going. And there was a question that said, you know, about lived experience. Yes, you gotta have lived experience. A lot of times I would really suggest to take somebody who understands the streets also, because the streets are a whole different language itself. It's a whole different movement. It's a whole different source. So, I mean, it helps if you know what you're looking for. And again, a lot of the people on the streets they'll let you know when something's going on.
One of the things that Thomas and Denise shared when we were putting together and preparing for this presentation is that to not push it when it's not there. You know, if you're approaching and folks are not engaging and folks are having short answers and folks are not looking at you, then just walk away. You know, that's a sign that it's not open, it's not welcome. And so why push it? You know, say thank you very much, and we'll be around next week, and hope you guys have a good day, and you walk away. Don't push it if it's not there. You know, but I know we want to be helpers. I know we want to save the world. But if it's not there, you're not feeling it, just walk away. Push it, leave before it gets escalated.
Thank you. There have been a few questions also from people about kind of trust building, and I know you all have touched on that, but are there specific strategies you use for building trust with folks, especially in a setting where it's hard to have privacy? So kind of how do you engage with folks when you're in an encampment setting and, you know, there's a lot going on?
Well, I mean, we've walked up to some encampments and they start whistling, you know, to let the others know that, you know, somebody's here that's not us, you know. And I tell them, you know, those are your felonies, not mine. I'm here to, you know, do you need water? What do you know? And right then and there, they just start. It's an icebreaker, you know what I mean? They know that we don't have any affiliation with the police. We don't have any, you know, we're there for them. And I mean, we've built enough rapport that you start to see people in different encampments, you know what I mean? So it's like we could walk in 25 people, and there's 3 of them we already know, and we're 20 miles away from where we were last week. So it's like their own little world, you know what I mean?
Yeah, they vouch for you, how they know that
Yeah.
they can say these people are okay.
Yeah.
Also, giving out pamphlets help out a lot, because they will share pamphlets with other encampments.
food resources. I mean,
Yeah.
we've walked up with grapes and stuff like that, you know, we don't ever walk up empty-handed. And you'd be surprised what a bag of grapes can get you in the summer.
Oh yeah, ice cold grapes in
Oh,
the
yeah.
summer. Oh, they're so refreshing.
I think consistency, being consistent and saying what you say you're going to do. Like I said earlier, not making promises. Um, just showing up when you say you're going to show up. I mean, trust has a lot to do with how you act, how you present yourself. Um, again, try not to go into an encampment with too many people at one time. That's overwhelming a lot of times. Always, my team always wears lanyards, always identify. You always got to identify yourself. So that way they know that it's an organization that's there to help. They don't think it's police. They don't think it's, other type of entities that's there just kind of like trying to scope them out and try to get them out or trying to harm them. So you just stay really consistent. And again, just a lot of respect and a lot of talking and a lot of letting them talk and a lot of just, showing them that you care and that, a lot of empathy.
The
And-
attitude that this is their space.
Yeah.
This is their home. You know, we are the guest. And that to come in with that kind of humility and respect.
Absolutely. I think those are key to, it's something we all want in our interactions, and certainly when we are coming into somebody else's place of living and really viewing that as their space and being respectful of the fact that you are a guest in that space. It switches the power dynamic to come out into the community, which is really important in gaining trust, especially when there's a healthcare component, because far too often individuals experiencing homelessness, those who have been marginalized by our society, have been mistreated by healthcare providers. Maybe not us specifically, but that we need to find ways to really distinguish ourselves from others who have, and recognize that we certainly do not deserve assumed trust and also may have to work harder to gain it.
When we approach an encampment, it's almost the same thing as approaching somebody's home.
It is.
You know, where you wait outside a respectful distance as you speak to them and begin to build some trust, some empathy. They're making the assumption, they're making the assessment if we're safe. And so we need to have a respectful distance while they make that determination if we're safe.
Yeah, it's a permission too. You got to ask permission. You got to identify yourself, let them know why you're there. But the permission goes far because you're entering their communities, you're entering their houses.
Absolutely. A question for you all about I hesitate to use the word typical because I'm sure the answer is there is no such thing as typical, but how do you structure your days in terms of when you decide to go out to the encampment sites, what times of day, and maybe talk a little bit about why you choose those particular times?
The weather, for us, it's the weather. I mean, in the summer, we're out at 5, 6 in the morning before it's getting hot, because you're not gonna find anyone wandering the streets at 2 in the afternoon, not in Phoenix, you know. Just like now, we start later because it's cooler, so they're hunkered down a little longer, you know. So it's done by the weather. We don't decide the weather changes.
Yeah.
Yeah, us, it's just, we don't have the big weather issues here. I mean, we do when it, rains or whatever, but we don't start on the street till about 9 in the morning, and most people are asleep then. We don't want to wake them. We don't want to bother them. They're a little cranky when you wake them up in the morning,
Mm-hmm.
So we don't, we don't have to deal with, it gets hot, but not Arizona hot, right?
Yeah.
It gets cold, but not back east cold. California is a little bit different in weather-wise, but we only work in the day. We don't work at the night. We don't work early in the morning.
Right.
We only work from about 8. We start at 8 and we're off at 4. So we usually don't go past 2 o'clock on the streets unless something is really needed. So, with us, it's a little bit more laid back. California, come on, man.
I think we have time for just a couple more. One of the other questions that has come up a lot is if, I think you guys have perhaps spoken to this some, but have you seen a change in your communities since June, which was the grants pass decision, allowing kind of opening the door a little bit more to, you know, being more aggressive with sweeping and displacing people, and also with ticketing and arrests? Have you noticed that there's been a change since that time in June?
Yeah, we just ran into a woman just the other day that she was taken to jail. They found something that was on her, but I said, were you under arrest? And she said, no. I said, well, they had no right. Did they ask you if they could search your stuff? She said, no. I said, that's not right, you know. Well, she calls her probation, or she calls her public defender, and sure enough, they dropped the charges on her. I told her, even though you're homeless, you still have rights, and don't ever forget that. But they'll run them off one encampment, and they'll turn around and go across the street, and they know that they got 72 hours there before they can hunker up and come back, and they just move back across the street. So it's almost like a game they play with them, you know. But they have nowhere to go. They have nowhere to offer them to go. So I don't understand how they can just keep, you know, trying to run them out of this neighborhood for the property values. Well, you know, you gotta have somewhere to live.
I wouldn't say there's been a major impact since grants passed. I would just say that there's a little bit more sweeps than usual, and that probably is affected by then. But again, we've been pretty lucky that we haven't seen a whole impact, but I think it's more here getting ready to, you know, jump up for the Olympics. So they're going to start moving them here, there, and everywhere. But again, like she said, they'll go from one side of the street to another or around the block and then just wait and come back. So there hasn't been, I wouldn't say really impacted anything since grants passed.
Just a lot more paperwork for them to do, because I mean, we have the homeless courts, and they go in front of the judge and he dismisses it. So you pretty much just waste a whole lot of ink and paper, because it didn't get anybody anywhere. It didn't solve anything.
Regarding community coordinated efforts, I haven't seen or read anything about that increasing since that passage.
But we have lost 2 big shelters too. So there's a lot of people that were put back on the streets that were in transitional shelters for some of them a year or 2, waiting to get housed, and then place they lost their funding closed down. So now they're all back on the streets.
I do think we're seeing more city councils and regions starting to make decisions. Just one announced recently in my hometown paper in Massachusetts, of a rather large city in Brockton, Massachusetts, making the decision. The city council announces that they are banning encampments. And so I do think we will see some of this. I hope both of your programs remain in areas where that is not the legislation that is acted, but I'm sure many of the attendees on our call are either seeing these decisions being made, or there is more of an environment where those types of decisions would be favorable or would be at least considered. And it will certainly impact the way your teams are perceived by community, by other community programs, maybe by your state, you know, whether it be your city or your county, your administrators within your region. So I think probably one final question here for today. What advice would you give to a program that wants to start doing this work? And when I say this work, I mean broadly. So certainly there's been specific questions about street medicine, but also touch upon I'm sure there are many programs on the call that are not yet doing outreach, that are not yet necessarily going outside of their brick and mortar. So please think of how would you encourage them, and what advice would you give?
When you go out on the streets, you run into some of the most warmest, and I mean, there's not a day that we don't get thanked for what we do. just for giving them water or just for showing up. And it's a totally different mentality than if somebody comes into your brick and mortar. And I mean, it's just right there. It's a game changer. It really is. So I think everyone should do outreach, meet them where they're at.
I think you don't have to recreate the wheel. If you're interested in doing this and getting it off the ground and figuring out the budget and the cost and how to begin, you don't have to recreate the wheel because, within the National Healthcare for the Homeless Conference, there's a lot of resources there. There's the Street Medicine Institute that also has lots of resources. And you have a lot of members of the National Health Center for the National Healthcare for the Homeless Council that can also be involved in supporting new programs. You don't have to recreate the wheel. We've
think the main
learned our
part of it
lessons.
Main part of it is just funding. I mean, you got to find the funding. You got to find the resources. You got to find who will support the work. I mean, either that or just get a whole bunch of volunteers, but you know how that goes.
Yeah.
Without the funding, though, that's the hardest part of the program. And we've been pretty blessed to be 100% funded with a bunch of different ways. So I think the very first step would be finding out who can back you and what it takes, and then who can come on from the backing, meaning like a provider, a community health worker, a nurse. Those are like 3 essentials that you really need in order to start a street medicine program. So just as long as you have the funding for your people, I mean, you can do as much as you really want.
So to that, I do want to take a moment. I am dropping 2 resources in the chat for everyone. There were quite a few questions around funding. And this is one in which things do vary greatly by state, because even those things that are Medicaid, that is administered at the state level. So I think the answer from all the street medicine programs that I have talked to across the country is there are multiple sources for funding. So the term braided funding is often used, just like most health centers, that is the case, that there is not just one funding source. So when possible, street medicine teams, health centers do bill insurance for those individuals who have it. That is certainly not 100% of their clients, but it is an important opportunity for revenue. There also are opportunities for partnerships within your city, within systems like hospitals and larger healthcare systems, wanting to meet the needs of their community, being tasked with that. So that is also an option. These are great resources that are here. Thank you to Raphael for promoting our conference that is happening in May in Baltimore this year. This is certainly a topic USC Street Medicine and the Street Medicine Institute have both published and present often on how they make this possible. And I think one of the things that has been clearly evident, and I want to take this as an opportunity for thanking Joseph, Denise, Thomas, and Raphael, is the passion in the people who do this work, and the commitment to finding a way to meet the needs of their community. Really, street medicine and outreach work stemmed from the fact that we know that people cannot access brick and mortar locations for a myriad of reasons, and that meeting them where they are in whatever interest they have at that moment in meeting with us and accessing care, and starting from that opportunity, that point of humility to engage and build trust and relationships. Thank you all so much for being here. It's been a real pleasure, and a special thank you to Joseph, Denise, Thomas, and Raphael for this afternoon.
Thank you, guys.
Thank you.
Great. Thank you so much. And on behalf of HHRC, again, thanks. Just wanted to, if we could bring up the evaluation codes while we wrap up. I also wanted to mention there are a lot of questions about further training on outreach. Just wanted to flag additional resources from HHRC. We received about 300 questions during the webinar, so I am sorry we didn't get to all of them, but we would be here all day through the rest of the week, which I would enjoy continuing this conversation, but we might need some breaks. So I wanted to let you know we are going to be preparing additional resources after this webinar. We're going to take all of these questions back with us and look through them and have them inform our work. So not to worry, this is the start of the conversation, not the end of the conversation. And just want to thank everybody for spending your time here. So once more, Alicia put the links to the evaluation surveys in the chat. And I think it's coming up in case yes, if you would prefer the QR code, we'll keep this open for just another few minutes. But thank you so much and have a great day. Take care.
Thank you, guys.
Thank you. Thanks. Bye.
God.